So you and I know what we're doing. Let's introduce ourselves and introduce what this is, and go from there. So I'll go first. I'm Vicky.
Okay.
I'm a 55-year-old female who's managed to survive and is still surviving menopause, in that I haven't killed anybody yet. So that's a good thing. Anyway, I manage a neighbourhood centre and a community centre, and I deal with people in crisis. And so what prompted my conversation with you was particularly around women in crisis and some of the things that I've been seeing that, and you and I have had conversations around education. So anyway, we'll get into that. But I'm Vicky, and you are?
And I'm Sarah, and my name's Sarah Nunn. I'm a doctor, and I work in general practice and specifically in women's health, or predominantly in women's health. And I have a strong interest in perimenopause and menopause. And some of that is because I'm 51, and this is a lived experience for me. I'm in the privileged position of helping women my age, younger and older, navigate what for many people might be a difficult transition in their day-to-day.
You're so tactful. A difficult transition. I would personally just say that that's the biggest understatement of the year. You and I both have lived experiences, and I would describe neither one of those lived experiences as a difficult transition. And I really think we should talk about that difficult transition. But anyway, tell our listener why it is we're doing this.
So, well, the statistics are. So the thing that really piqued my interest not that long ago was learning that women over 50 represent a growing population of homeless people, and that the changes that we experience physically, psychologically, emotionally, in our day-to-day, in our relationships, contribute very strongly. Well, evidence tells us that those experiences contribute very strongly to awful and invisible disadvantage in our community. And so what the evidence will tell us is that 2 in 10 women don't have too much trouble with perimenopause and menopause. 6 in 10 women will experience enough disruption that it affects their day-to-day, and 2 in 10 women, or 20% of Australian women, will experience devastating effects of
awful effects.
Awful, generally dreadful, and that historically there are, in the not too distant past, reasons why medically and socially we've failed to respond to what is essentially 80% of the female population, which makes up 50% of the Australian population. So no small thing.
No small thing. But I think I remember we've had a number of conversations about this, from me from the social aspect, you from the medical aspect. And I remember a couple of text messages from you and calls from you, and you're just like, we've got to do something. We've got to get this information out there. So, I see us doing a series of these informational videos. So ultimately for you though, what do you want people to take away? And I do say people, because even though perimenopause and menopause affects women are somebody's daughter, somebody's wife, somebody's sister, somebody's work colleague, and basically, the domino effect is this affects everybody. So what do you want people to take away from these informative, and I hope they are informative videos that we're going to do?
Yeah, and I think that was really perhaps what sparked us into action, was the very clear understanding that it's not just women who are suffering. It's not just the number of women who end up living in their cars. Everybody loses. Their partners lose, their kids lose, huge amounts of productivity from a broader economic aspect are lost. And so we're not just talking about women who are suffering with a range of symptoms, physical vasomotor symptoms, psychological symptoms, anxiety, brain fog, low mood. Everybody loses.
That's right.
Everybody loses.
It's so true. And maybe just for the purposes of this very first video, I'll clarify what we're talking about in terms of the homeless women living in their cars and how this came about. So I remember I had a conversation with you, knowing that you're a really great, awesome doctor working in the women's space. And I shared with you that I had 3 women in the space of about 2.5 months, unknown to each other, all over the age of 55, who were all living in their cars. And when I sat down with each of them and really peeled back the layers, because we know, well, I know, and those in our sector know, anybody who's living in their car, that's the symptom. That's not the reason. There's a whole pile of things that happen for them to get to that. And these women, when they started to tell their story, each of them, all 3 of them basically said, in the same words or similar, that all was going swimmingly until I started going crazy. And crazy wasn't their word either. It was what they'd been called by their adult children, what they'd been called by their husband, what they'd been called by their work colleagues, and in some respects what society calls them. Because the first thing that happened for these women, and their stories were just so familiar and of course ended up resonating, but was that first of all their relationship with their adult children broke down because they were no longer putting up with their shit anymore, and that went sour really quick. And then their relationship with their partner or husband broke down because she was no longer putting up with his shit anymore either. And then that turned so bad that even though physical domestic violence wasn't part of their story, it became part of the story because he just was like, you're fucking crazy, da 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 da. And then the domino effect of that was they weren't able to keep up their employment. They weren't well, they weren't, things were going bad at home, all the rest of it. And just this avalanche happened. And it was all from menopause, untreated menopause. And now these women who historically at their age were women that stayed home and brought up their children, and worked in kind of, hospitality jobs, retail jobs, things like that, didn't have the same kind of super their husband did, didn't have the same skills. Their husband used to do all the bills and stuff like that. So their husbands came away with the house, and they've ended up in their car, totally isolated from their family and self-medicating with drugs or alcohol. And that was 3 unrelated women over the space of 2.5 months. And I was just like, oh my God, the domino effect is truly societal. And as you were saying, everybody loses. And so we had this conversation, and then you shared with me some of the stories of the women that you see that come through your medical practice, just in such a state. Hey.
Oh yeah, and asking the question, what's wrong with me? And I think one of the things that really stuck, well, one of the so many things that really stuck with me and particularly about the group that, you're talking about, the 3 women, is how intensely invisible they are, because they have to be, because they're so vulnerable.
Yes.
In every sense of the word, they've got to be invisible to maintain their safety.
Yes.
And I think one of the biggest drivers, one of the things that worries me, is that once somebody's at that point where there's been such a huge domino effect, relationships are broken down, somebody's living in their car, if you start to trace back, the awareness around menopause, yes, is a huge issue. What I'm really keen to emphasize is what comes before that. Once the lemming's off the cliff, it's too late.
That's right. And I didn't either. People don't understand the difference between perimenopause and menopause. They don't know there is a difference. And so I know this is one of your passions, education. I mean, aren't you training doctors and nurses at the moment? Educating them?
Well, yeah, later tonight I'll be doing it's run by the RACGP, which is the Peak College of General Practitioners, around learning to be a supervisor for junior doctors. Because I suppose you reach a point in your career where you kind of, the medicine stuff, but we've never been taught to be teachers.
That's true.
Yeah. So that's part of, I think, my next journey is learning to be a teacher in that setting for junior doctors and for medical students as well.
And then here we are doing these videos, which are going to be educational, because I know for my journey, if I track it back, it was a hell of a lot earlier than the last couple of years that's been diabolical. But I didn't have any education around that. And I was seeing doctors, I was seeing my GP, and it was kind of like, well, we can't find anything. This just is your lot. You're getting older. This is what you can expect. It was really not helpful.
Yeah, and I'd like to think that space, I mean, this year, we've seen some of the menopausal well, when I say this year, I mean like last month.
That's this year.
Seen some of the treatments, for some of the critical treatments for menopause that make menopause treatment safe, come onto the pharmaceutical benefit scheme.
Yes.
And so, part of me's furious about that. And, as a postmenopausal woman, you're probably not going to win with me. I'm probably going to be furious about just about everything. But,
let's use your powers for good.
Yes. That's what I'm trying to do. Yes. So, I mean, if you look historically, which I think is really important in this context, that in the 1990s, 2000s, it was established that hormone replacement therapy or treatment, menopausal hormonal therapy, so we call it HRT or MHT, depending on what sort of mood you're in, was linked with an increased risk of breast cancer and blood clots, and you could argue about those particular studies, the robustness, the relevance of them. At the same time, we have come a long way. And so, whereas when I went through medical school, HRT, MHT was regarded with a degree of fear. So, you've got somebody who's in distress, who's experiencing lots of symptoms, and the last thing you want to do is give them breast cancer or, find other ways to harm them. So sometimes in medicine, it's not that you don't want to have the conversation. It's just that if there's nowhere to go with that conversation, what do you do with that? And I think that there is residual fear.
Oh, absolutely.
that's left over, not only amongst the general public, but in the medical profession itself, where if you're not confident in that space, if you're really not up to date in that space, then of course the mantra is going to be first do no harm, and I think that is intrinsically behind some of the reluctance of some of the medical profession in engaging in this space. I also think, and rightly or wrongly, that sometimes until you've gone there, it is hard to understand if somebody's talking about brain fog. What do they talk? What does that mean? If you've got aches and pains, what does that mean? Maybe you are just getting older. Can't sleep. Maybe your sleep hygiene's not great.
Sleep hygiene.
Yeah, something like that. Yeah.
There's hygiene with sleep.
It's a thing, Vicky. It's a thing.
Oh my gosh, I'm going to learn heaps. I'm sure I'm going to learn heaps from you. But you're not wrong about that stigma. It was part of anything when I first started to research what the hell was going on with me, because everything else was the same, but I was turning into this homicidal maniac.
Oh yeah, that
I would not. But having said that, I would never have been able to run after anybody to kill them because everything ached and hurt. So, I mean, I was only going to be homicidal if they were in this space. And again, hardly anybody got in that space because I was not doing people at all. But I remember when I started, there was all this stuff around HRT, and I came to know that yes, those studies are now outdated, and that yes, the HRT space or MHT space is a hell of a lot more advanced. And I can say from personal experience that the things that I've tried in that space, the HRT, have made a difference. Because here I am talking to you, not from my jail cell, not in an orange outfit after having killed someone, because that was potentially a very likely outcome.
And it's really it's kind of insidious in a way. One of the things people will say to me when for example they come in and they're just starting to be a bit beside themselves and with the homicidal thing, and they'll say something like, I've got road rage. I don't. What's happening to me? I yelled at a car that may or may not have pulled in front of me, or there was one lady I remember who talked about and this is nothing against cyclists, good luck to you, but a cyclist who'd perceived that she'd cut him off or gone too close and promptly, banged the car and started yelling at her, and she just couldn't stop crying. She had to pull over. And so these kinds of seemingly fleeting, socially unpleasant and yet at the same time innocuous events became big.
Major.
Because they knew. This is not something that I would normally. I'm a patient driver. Normally, if somebody appears to lose their bottle at me, that I'd probably deal with that, shrug it off, and that'd be that. But these things become big, and it's very hard to understand when you don't perceive that as part of your personality or part of your history. Seemingly minor, not conflicts in the workplace, but disagreements, differences of opinion suddenly become all-consuming. And yes,
I can talk about people chewing with their mouth open.
Oh, breathing. Yes.
Breathing.
Yes. Breathing is problematic.
I would have thought. And just something that I've never even noticed before. I've now noticed it and realized I hate it. Hate it. It's not even I'm mildly annoyed by that, or that's annoying. No, I hate it with a passion. And that those emotional epiphanies, if you like, because it was an epiphany, like, whoa, chill. I couldn't even do that for myself, to go, well, take a chill. You need to just walk away. I didn't even have the ability. I was so wound up in that space to be able to pick myself up and walk away. Even those previous strategies of dealing with conflict or issues, I wasn't able to grasp onto. They just were not in my brain space.
Yeah. And that's this sort of block. You can't just sort of say, well, I'll go for a walk in the park, or I'll go and sit in my garden and or sit on my balcony and have a cup of tea. You just can't quite get there, and the things that used to calm you down don't. And they, and of course that heralds something else that's going on. But if you only go through menopause once with any luck.
Hey, well, I heard it comes back. But I mean, is it, in my mind, did it really leave? I mean, but I have heard women say, oh, it came back. I'm 70 years old and I'm getting hot flushes again. Like, please tell me this isn't going to happen. How do I make sure that doesn't happen? Why would a woman think that it's come back?
Yeah, so, I mean, so what's menopause? Menopause is the last period. And of course, you don't know that that's happening when that's happening. It's all a little bit retrospective.
Yes.
The period of menopause or perimenopause. So menopause is the last period. Okay. Perimenopause is what comes before and after that. And when you're 12 months after your last period, that's postmenopausal. The menopausal sort of symptoms last on average around about seven years. And the literature I read earlier today put that closer to 10, and then I had to have a lie down and a little bit of a cry.
God, you're joking.
But yeah, it often starts to hit in the early 40s. So the scientific and the very, very, very well understood reason behind that is that the ovary, the production of progesterone and estrogen starts to fluctuate. And again, as our understanding of menopause evolves, we know that, 30, 40, 50, 100 years ago, we'd say low estrogen causes menopausal symptoms. Well, high estrogen causes menopausal symptoms. Also, bouncing between the two causes menopausal symptoms. So it's the changing of the estrogen production predominantly.
And this is their hormones, right?
Yeah, they're hormones. Yeah. And I kind of look. I'll give you my hormone speech, because I think we throw around this word hormones. So yes. What are they?
What are they?
What is a hormone? Right. And so I'll often say to people, patients, so, all right, your brain communicates with your body. Well, it's very well understood in the population, with the nervous system. So the nervous system is from the brain to, down through the spinal cord to my hand. That's my nervous system. And that's an electrical system. So that's the same. And a neurologist would vastly disagree with me, but just run with it. No hate from neurologists or neurosurgeons. It's an electrical system. It's the same as my light switch over there to my light. I turn on that light and an electrical current travels to my light, and there we have it. And so that's a physical connection. So if you disrupt the nerve that runs from my brain down to my hand, that won't work. It's a physical, if you cut that system, not going to, but if you cut that system, that's not going to work.
Good to clarify.
Anyway, for better or worse, the endocrine system is another way that your brain communicates with the body. And I, in my flawed logic, liken that more to Australia Post. So my brain wants my body to do something. And during your fertile years, one of those things is to have an egg to have a baby. So my brain sends my ovary a letter, and that letter says, "Dear ovary, it's that time of the month again. Would you mind giving us an egg, because we're going to have a baby, and can you give me some estrogen?" And the letter goes to the uterus, and the letter says, "I've just asked ovary for an egg. Now we need somewhere to grow this baby. Can you grow me a nest? That'd be great, and get me some progesterone." And so there's nothing that system is discrete parcels of information that go from the brain to target organs, and there's a whole bunch of them. There's a big long list you have to learn in medical school, and I'll
leave that with you.
I'll leave it with them. I don't know. So in the case of, you during your fertile years, that works more or less regularly. We talk about a 28-day cycle. I mean, very few women have a 28-day cycle. You kind of get the idea. Yep. That on occasion, these instructions.
The letter gets lost in the post.
Yeah. Yeah. And sometimes the brain dispatches 2 letters at once, and yeah. So, but the system is more or less regulated on that monthly sort of cycle. When you start to run out of eggs, which is what happens as we get older, and typically famously declines quite quickly after 40, the ovaries just don't respond. So the ovaries go out to lunch. So the letter arrives, but the ovaries they're out. Yeah, and sometimes they do. They have a long lunch. They come back. They're worse for wear, and they may or may not participate in that cycle. And so it's the formation of the follicle that holds the egg in the ovary that produces estrogen. And so if the ovary is not responding to that stimulus, is not producing an egg, is not producing the formation of that egg, then your estrogen is going to fluctuate. And estrogen is tremendously important for the brain, hair, skin, muscle, heart, bones, mood.
Well, that explains a lot.
Yeah. So estrogen, and you don't want to underestimate progesterone because it's there in the mix. But essentially, as you run out of eggs, then the ovaries aren't responding to what they're being asked to do, and therefore not producing estrogen. And the brain is, of course, very, very sensitive to that. There are some interesting theories that estrogen makes us patient. And so the lack of estrogen, or too much estrogen, or fluctuating estrogen, the physiologic basis of that is that the brain may be more or less happy with that situation.
Oh my God.
Expressed in various different ways.
Oh, well, I've come to know, though, you were talking about the brain, the skin, the hair, the this, the that, the fluctuation of estrogen in my body, and then the gradual decline, and then it's gone, because that's what it felt like, absolutely manifested in all of those things. I turned grey. My nails became brittle. This word patience, I don't understand that word. That can't say that's been part of my vocabulary at all during this process. And there'll be others who'll say I didn't have it even before then.
Yeah.
But like the brain fog, you were talking about, what is brain fog? I know what it was for me. Same with the aches and pains and things like that. Like, oh my God, I feel like what I think a stereotypical sort of 80-year-old woman looks like, all bent over, hunched over, and just shuffling along. I feel like I'm like racing towards that.
Yeah, I think one of the least talked about symptoms, which in polite society may or may not have a place, but that's the genitourinary symptoms. So that's the stress incontinence, the urge incontinence, the the prolapse of the bladder or the bowel, dry vagina, loss of libido,
UTIs?
Absolutely, absolutely. And these are the things that sometimes you really have to prod people to acknowledge and talk about. Nobody wants to admit to having to wander around with a pad, and their husband wants a cuddle and they'd rather stab him.
Or the dry vagina, so dry that you need to wear 2 layers between everything to keep everything just flowing.
Yeah, and back to the estrogen also affects the elastic. I don't know if you've ever had an old pair of undies that's just died because the elastic's died. Some of the elastic that suspends the pelvic organs also tends to get less elastic, and interestingly that can then also unmask some of the trauma of childbirth.
Oh God.
Where
I bet.
Where I mean, so yeah, it's a big.
So what I'm getting from you, and what I also know, is that that the stereotypical hot flushes is like this much of perimenopause and menopausal symptoms, and there are a plethora of things that can happen to a woman's body, and each woman is different, and the degree to which these things happen are different. But I remember frozen shoulder.
Oh yeah,
and
yeah.
Like I said to my doctor, what the hell's my shoulder got to do with my vagina? What do you mean? And then I was at a meeting, and I happened to say to my colleague about this frozen shoulder. She goes, oh yeah, man, I've had this, blah blah. And then 2 other women. So there was 4 of us in this one meeting, all women in our late 40s, early 50s, all talking about frozen shoulder.
Yeah.
Please, like, who would have thunk? I just thought it was years of playing softball. I switched to baseball. I stuffed it all up. But in actual fact, there's a hormonal reason for this. Tell me why my shoulder has got anything to do with my vagina.
Yeah. The evidence suggests that frozen shoulder is a really big issue for perimenopausal and menopausal women. And again, not an orthopedic surgeon. I do think though it is linked to that loss of elasticity, changes to the fluid that lubricates our joints. There is muscle changes, bone changes. So yeah, there's a really high incidence of frozen shoulder, of all things.
Of all things. It truly made no sense. I mean, and yeah, what I'd like to do with our videos is to make those things make sense. That like the frozen shoulder, the god awful itchy ears. Like honestly, who would have some of the symptoms I just never would have put together. And it's just that I came to know after COVID that I really needed to be assertive with my healthcare. And so, I've done research on this, which is how you and I started having conversations. But just the normal average woman out there, and I go back to those 3 women that I spoke to, that no one had ever had that conversation with them. Ever had the conversation with them that there might have been a hormonal reason, a physiological reason for some of those breakdowns. And here they are now homeless. And like you say, that we're way too late. potentially way too late. Well, way too late to, like fix this living situation, but hopefully not way too late. Thankfully now that the Australian government has put a number of these treatments on the PBS. Thank you. But in the meantime, yeah, I'd really like to, with you, unpack and tackle some of these things that are happening to women that they're not even attributing to this, because that's literally what happened to me. And I think if I'd have had some earlier help, I would have had, less homicidal tendencies, and certainly a lot less tears and frustrations. And yeah. So what do you think?
I mean, I think I wouldn't for a second minimize the vasomotor symptoms that some women do experience. So a hot flush is not just like, oh, it's a bit, get me a fan. No, it's like being dipped upside down in boiling oil. It's where you're in David Jones or Myers or, somewhere, and you go tearing into the changing room without something to try on, and just rip your clothes off and just try not to die. And
nobody comes in the changing room, because you'll have to kill them.
Well, that's right, but you don't care at that point, so it doesn't matter. And the other thing is, the night sweats, the women who wake up multiple times during the night and have to wash their sheets and change their clothes only to go back to sleep and wake up later and wash their sheets and change their clothes. And I mean, ironically, winter can be particularly cruel, because you wake up in a lather and you're freezing.
Yes. Oh, look, well, so yes, these are all the things, and no, and you can't in some ways tell anybody about that, but we are going to tell everybody about that. Like you say, being turned upside down, dipped in hot water. Another menopausal woman will know exactly what you're talking about. But like we said earlier, this information is for everybody, for the husbands of these women, for the adult sons of these women, the male work colleagues of these women, and the younger women. Because I'll tell you right now, my daughters, and we have a great relationship. I don't want to paint anything other than that. But they got sick of me saying, oh, it's because of menopause. Oh, it's menopause. And they truly were just, whatever. Oh, let me guess, Mum, it's menopause. Like they started to give me, they were sick of hearing about it until somebody else told them. As is true with anybody's child.
That sounds right.
Yes. So I really want us to unpack those things that are happening for women that they're not attributing to this kind of change in their body, and so that they can get onto the stuff really quickly.
Yeah, because I mean, it's really tempting as a GP. So somebody comes, patient comes in, they've got aches and pains, and they think, oh, well, here's another one. I've put on a bit of weight, and now my knees hurt, and I've been working for years, and, I do repetitive typing or something, and all the joints in my hands hurt. And so you might, for example, screen for osteoarthritis or rheumatoid arthritis, or go looking for some sort of autoimmune condition, and everything comes back normal. So what is their experience then? Do you just say to them, well, look, it'd be really good if you would lose weight. Yep. And, let's look at your diet, and,
and then
maybe
physio.
Maybe
physio was one of the other ones that I was referred to.
Yeah, and physio definitely, and no dispute, like physio's definitely got its place, and weight management is really important. They are I think what you said before, they're the symptoms, they're not the cause.
That's right.
And so putting the picture together will allow someone to engage with physio. you can't engage with physio if you're in screaming amounts of pain, and the physio is not going to be able to be as effective as it possibly could. You know, if your weight distribution's changing so that you're getting more central kind of weight gain, your muscle mass is changing, your bone mass is changing, just putting someone on anti-inflammatories is not a bad idea, but not, and at the same time is not really addressing the root cause of what's going on, which is a little bit more sophisticated and is not just limited to, you know, knee pain when you go for a walk.
Yeah, that's so true. Well, let's do this then, because this was our introductory video. I did, you know, we want to keep our videos around half an hour, you know, just get some short, sharp information out there. And but I think, you know, we've covered quite a bit in this, you know, coming from, you know, like tasters of where we're coming from, why we're doing this, and then what we hope to achieve. And so what I also envision is hopefully, you know, we get one or two listeners who might want to ask a question, because like we've both said, this is a personal experience. Yes, there's some commonalities, but it'll be degrees for depending on a whole pile of things. And I know when I was in the throes of it, I'm not freaking interested in anybody else. This is what's happening for me. Tell me what's going on and tell me what I need to do to make it stop.
Yeah, so the government actually blessed their cotton socks. MBS released the new item number today for perimenopause and menopause, which is the first time I think that it has been explicitly recognised as such a major cause. You know, we're talking about women in their early 40s, mid 40s. They've got families, they've got mortgages, they're mid-career, they're achieving. And how do we stop that going to hell in a handbasket? Because we can.
Yes. But 2025.
Yeah,
we're
I know.
2025, and this is, you know, it's only a conversation now with our government, to the point where they've now amended the system. 2025
was introduced today, was day one.
That's unreal. Well, my friend, I think that was a really, really good intro. I so value your time and your expertise. I know just our conversations have been really beneficial for me, and I'm really keen to impart some of that wisdom of yours to a greater audience, because it's certainly topical in my friendship group. I would no doubt topical in your friendship group. And I, every time I talk to a woman, they're just like, oh my God, don't even start. But I think we are starting. We're going to start with some information. And hopefully a whole pile of women out there will go, oh my God, I'm not going crazy after all.
No, and don't put up with it. You don't have to put up with it. Just like we don't expect, you know, we nurse our adolescents through those early years, you know, those early fertile years. Well, it's the same.
It is.
Well, it's not quite the same.
Wow.
It's kind of the same. You know, yeah, we allow our adolescents hopefully allow our adolescents to experience the changes that their bodies are going through and support them through that. And it's no different.
Oh, well, I remember I used to tell people that some alien ship came down and stole my daughter and left me with this bitch from hell. And I just want the ship to come back and bring my daughter back. Where did she go? Which planet is she on? And they did. The alien ship did bring her back eventually. But I think, you know, they came for me. And for me this time.
It was a trade.
So anyway, look, let's end that there. That was really cool. Thank you for your time.
That's all right. Thank you.
I think let's do this. Okay.
Yeah, go on ahead.
Well,
all right, Vicky.
I'm going to try and work out how to stop the recording. And but you and I will talk again.
Okay. All right. Mwah, mwah,
Okay.
mwah. Love you.
Love you too. Bye.
Bye.